Okay, so we can go ahead and get started. So today we'll be hearing from Dr. Lorenzo-Luaces. He's an assistant professor in the Department of Psychological and Brain Sciences at Indiana University, Bloomington. He received his PhD in clinical psychology from the University of Pennsylvania in 2017. He's authored over 40 journal articles and book chapters and received numerous prestigious awards, including the Association for Psychological Science Rising Star Award, the International Society for Bipolar Disorders Best Paper Award, and the Aaron T. Beck Student Achievement Award. So Dr. Lorenzo-Luaces is broadly interested in the treatment and phenomenology of depression, including its classification and differentiation from normal sadness. His research is focused primarily on outcomes and processes of change in depression treatments, especially cognitive behavioral therapies. So we're excited to hear more about Dr. Lorenzo-Luaces' work. So we'll go ahead and turn the meeting over to him.
Thank you. Thanks for that lovely introduction. The title of my talk, it's up there. Hopefully you can see it. And hopefully you can surmise from that I'll talk a little bit about the heterogeneity in depression and some of the obstacles that it represents for psychotherapy research and really treatment research more broadly. Because we're psychologists, I have to say pitfalls, but also opportunities, and so frame it a little bit in the positive. Before I get started, I want to acknowledge my colleagues here at Indiana University, my lab, but certainly also colleagues who are not from Indiana University, especially some of my collaborators from Amsterdam, including from the VU and Maastricht. And also acknowledge that some of my time in these projects is funded through internal grants at IU, as well as some external grants that you can see up there. I also wanted to make a small caveat. A lot of what I'll be talking about is depression, but some of the arguments that I will be advancing, I think, apply as well to depressive symptoms as a continuum or the category of depression, as they do to other common mental disorders, specifically the internalizing distress disorders. So thinking about things like generalized anxiety, for example. And I'll be using a couple of generic labels like therapy orientations, and what I mean is really kind of collections of techniques, and we can classify them as therapy orientations for shorthands. And a lot of the arguments are about CBT because it's the therapy that I was trained under and that I'm most interested in. But again, the arguments I think apply more broadly to psychotherapy research and treatment research. Just to give you kind of an overview of what I'll be talking about, I'll discuss very briefly discuss the Jodeberg verdict in psychotherapy research and the common factors theory that accompanies it. This is a very, very old debate, and a lot has been written about it. So I'll give you like a very brief snapshot of it. I'll discuss how I think the heterogeneity of depression, I think, makes it difficult to, even to this day, make solid conclusions about the state of outcome in psychotherapy research and even about process outcome relationships. And I'll talk about two ways in which people study heterogeneity. One way, which is heterogeneity of symptoms, and another way, which is what I focus on, is really in the heterogeneity of the prognosis. I'll show some data from simulation studies and secondary analyses of randomized controlled trials on how I think prognosis makes it difficult to make solid conclusions about outcomes in different therapies and also process outcome relationships. And if I have enough time, I'll talk a little bit about some of the research that my lab is doing on low intensity treatments, including kind of meta research, so research on the research base, as well as ongoing data collection efforts. I probably won't have enough time to talk about some of the work that we are doing, characterizing the vulnerability to depression and other common mental disorders using social media data. But that's also another line in my research that I'm happy to talk about if I have time or outside of the talk. Hopefully, I don't have to remind an audience of psychologists the symptoms of major depression. I'm listing them up here according to the DSM-5. You know, technically, major depression is more than just the list of symptoms, and there are other criteria like the distress and impairment, and making sure that the symptoms don't seem attributable to a general medical condition. But by and large, most people who meet the symptom criteria meet all the other symptoms, and most episodes of major depression are really major depressive disorder and not bipolar disorder or schizoaffective. So I'm just listing the symptoms here as a reminder. Most of you should also know that depression is a leading cause of disability worldwide. Depending on which WHO statistic or figure you're looking at, it's either the leading cause of disability or the third leading or among the top 10. Either way, it is a leading cause of disability, especially if you're adding in also anxiety disorders and comorbid conditions. So this is obviously a big public health problem. If you are somebody who studies psychotherapy, you may be encouraged by the fact that we now have what I think is enough evidence to say that psychotherapy is effective relative to control conditions, including waiting lists, treatment as usual, and placebos. But the effect sizes are not, they're not very impressive, especially the more that you compare psychotherapy against something that's a little bit that looks a little bit more like an active treatment. You may, as some of us are disappointed you may be disappointed by the fact that there don't seem to be really large differences in outcomes between types of psychotherapies. If you ask me, a little bit of signal in the literature is that therapies that seem to be directive, that encourage the therapist to foster a change in the patient, may be more effective than control conditions or conditions that are non-directive and non-specific support. But even I think that conclusion is debated by some people, because a lot of the times these non-directive supportive therapies are really used as controls. And so some people claim these are not fair comparisons. Some also think, although I disagree with the statement, that the support for theory-specific mechanisms like cognitive change and behavioral change is weak. One explanation that's been put forth for why we don't find a very large effects of therapies, or certainly that one therapy is more effective than another. Actually, no, before I go into the explanation, I just want to give one example. So this is an example from a randomized controlled trial that my colleague Ellen Driesen did in the Netherlands. This is a trial that had 341 patients with depression, and it was analyzed as a non-inferiority study. I'm not showing you any statistics on the trial because you shouldn't need to see any statistics. The graph shows the depression scores over the 21 weeks of treatment in CBT and psychodynamic therapy, and the lines are basically on top of each other. And so this was a study that Ellen recently did, and it coincides with meta-analytic reviews and other studies that show no differences between the therapies, even though the therapies differ in some meaningful ways. So one explanation for this pattern of findings is the idea that maybe there are commonalities, sometimes referred to as common factors, between different types of therapy. And one of the common factors that has been most often researched is the working alliance between the patient and the therapist. When most people think about the working alliance, I think usually they think about the level of kind of the affective bond, like how much we like each other, how warm the relationship is. And the construct certainly includes that, but it also includes the level of agreement that there is in the goals and tasks of the therapy. And of course, most of the measures ask about both things and really heavily ask about the agreement in the goals and tasks of the therapy. Roughly 10 years ago, when I made this slide, the Alliance was the most widely studied psychotherapy process research. I haven't updated the slide because not a lot of things in it would change. It's still the most widely studied psychotherapy process research. It still has a correlation to outcome that's roughly in the effect size of an R-type of 0.28. We can debate about whether that is big or small, but that seems to be reliable. If you ask me, there are a lot of limitations in this literature, two of which I've listed in the slide, but you can take this as face value and say this could be one explanation for the pattern of findings that we see, is that all these therapies primarily work through common mechanisms, for example, the alliance, and that's why we're not really seeing differences in the outcomes or large effects when we're comparing to even conditions that you may think are controlled. A lot of us think that despite the fact that there's a lot of research on the Dodebert verdict and the working alliance, that it may be premature to conclude that all therapies, sticking with depression, are equally effective, because there is a lot of heterogeneity in the kinds of patients that we see, and possibly in the kinds of interventions that they benefit from. And this is exemplified by the Gordon Paul quote that I'm listing up here. Most of us shorten, by what treatments work for whom. And I think, I'm a heterogeneity person. So if you look that up on my CV, the word comes up a lot. So obviously I care about heterogeneity, but I also think it's a little bit cheap to say, oh, heterogeneity makes it hard to make conclusions about psychotherapy research. It's not really saying anything. So really a key question is, what is the kind of heterogeneity that we could be studying that may lead to different conclusions about the efficacy of psychotherapy or about the mechanisms of psychotherapy? And most of my colleagues who are heterogeneity people focus on the symptoms, right? There's 9 of them. Broadly speaking, you can categorize them into 3 different domains, but that seems naturally like a source of heterogeneity. Because it's a polythetic set, it's been calculated that you can meet the criteria for major depression over 10,000 ways. And without any kind of frame of reference, that seems like a really big number. So it seems like a natural source to study heterogeneity. The DSM committee recognizes that there is heterogeneity in these polythetic sets. And it already provides us ways in which we can make more homogeneous groups of patients by using specifiers. So one of the specifiers for depression is a melancholic feature specifier. And I want to distinguish the specifier of melancholia from the idea of melancholia. So the idea of melancholia is very, very old. Like it goes back to the ancient Greeks, not just the word, but even really kind of the idea of there being this different type of depression. The specifier was first operationalized in DSM-3 in 1980, much in the same way that a lot of the criteria that we use were. And basically what it's supposed to capture, the cardinal feature is low positive emotionality. And in the DSM, you can meet that by having anhedonia, which is loss or decrease of pleasure or interest, or by having a lack of mood reactivity. So your mood doesn't brighten even if good things happen. So that's kind of one cardinal feature of melancholia. To meet the full criteria for the specifier, you must have 3 symptoms from a list of 6. Some of the symptoms of melancholia overlap with the symptoms of depression, and some of them don't, and they are added features. In the slide, I have colored the added features in green. And they are basically finding that your mood feels different to you than just being intensely sad. It's also waking up earlier than you would like in the morning and feeling like your depression is worse in the morning and gets better throughout the day. The last 2, which are connected to the belief that melancholia is tied to hypercortisolemia. So there's 10,000 ways of meeting this criteria for major depressive disorder. Akerfried and I asked recently, well, how many ways do people meet criteria for major depression and melancholia? And we published this in Lancet Psychiatry as a letter where we calculated that there are over 300,000 ways of meeting criteria for melancholia. Now, when most people see this, the reaction has been like bimodal. A lot of people will say, this can't possibly be right. It's a specifier. It identifies fewer people. The group must be more homogeneous. And then some other people will say, yeah, well, of course, if you take a polythetic set and then add a polythetic set, it's just going to be an explosion of heterogeneity. And in fact, I think there was a letter response to our letter saying something like that. But this is the way in which the DSM has promised to study to reduce heterogeneity within the system. And we are showing evidence that at least conceptually, it doesn't do that. It allows for there to be more heterogeneity by adding symptoms. We have actually also looked at this in real data. So the calculation is kind of conceptual, right? It's like, does the DSM system allow for melancholia to increase heterogeneity? The answer is yes. We have also looked at clinical samples, the STAR-D in a preprint that's up on, you should be able to find it on my OSF or Google Scholar, and also have looked at this in the NESARC data. And in both data sets, melancholia increases heterogeneity when you are adding the melancholic symptoms, but even staying with the symptoms of depression, it does not seem to reduce heterogeneity. So this category, like the category of melancholia, does not appear to reduce heterogeneity in a meaningful way, at least in the way that it can be quantified by the symptoms. And then there are also other pieces of data that argue against the idea that these categories help us to reduce heterogeneity. One of the most, I think, damning ones to me is that it doesn't predict differential response to some of our major treatments, including CBT, antidepressants, TCAs, SSRIs, or MAOIs. I don't know that a lot of people agree with this statement, but I'm willing to share some of the references I used to make this statement. It also seems to be the case that the support for these categories as biomarkers is a little bit weak. And they also don't seem to be stable within person, which you may or may not think is meaningful, but I certainly think it argues against the utility of the category. Data-driven approaches to look at the ways in which symptoms naturally cluster, in my estimation, have not been that much better. Some symptoms change a little bit more or a little bit less with treatment in general, but it doesn't seem to be the case that they help us match people to psychotherapy versus pharmacotherapy, or certainly to different types of psychotherapy. And all of these are like the holy grails of treatment research. But I really think, I'm a strong believer that symptoms are not the way in which we are going to figure out the problem of how to allocate people to the best treatments for depression. So the question is, okay, well, fine, not symptoms. Are you willing to believe me? I hope. What should we be focusing on instead? So in my research, I care about also the level of heterogeneity that there is in the prognosis of depression. Most of us are used to reporting that anywhere from 17 to 20% of people will meet the criteria for depression at some point in their life. Those figures, of course, come from studies in which people are asked about their depression retrospectively. So you have to think about your entire life. And we have enough studies now to know that there's some recall bias that happens in studies where people are assessed repeatedly over the life course. The lifetime prevalence of depression balloons up to 30 to 50% by the age of 30. So this is an experience that is much more common than we typically, I think about in clinical psychology. When I see papers in most of the clinical journals that I read on depression, they usually highlight how it's very chronic and how it's very recurrent, which is true in clinical samples. But in epidemiological samples, there is a little bit more variability in prognosis, where a lot of episodes are brief. It's not to say that there is not a subgroup that has very chronic depression, but a lot of the episodes are brief, and they're also unlikely to recur in the 20 to 30 year follow-up periods that we have, including from people in your faculty. So there is this kind of like heterogeneity in the chronicity and in the recurrence of depression, as well as in the placebo response. And I think this is one area where we really should be focusing on if we want to get more serious about reducing the public health burden of depression by doing a smarter job of allocating people to the treatments that they may benefit from. This is not an insight that I had. So in other areas of medicine, prognosis or your expected prognosis is used to guide you to different treatments that you could benefit from. So for example, in breast cancer treatment, the prognosis can be used to allocate you to the kind of intervention that you may benefit from. So people who have a good prognosis they may do just as well with treatments that are very intense, like a full mastectomy, as they do with a treatment that's less intense, like breast conservation therapy, whereas people who are a higher risk category may benefit more from a treatment that is more intensive. There seems to be some support for this idea in the cancer literature. So one of the questions that guide my research is whether that is true in depression. And also, if it is true, like, what is the implication? Like, how big of a problem or an opportunity, if I'm being more like a psychologist, is it? And one of the ways in which we've addressed this heterogeneity in prognosis recently is by using simulations. So simulating a randomized control trial data. So this is a study that I'm doing with Lois Gelfand and other people at the University of Pennsylvania, where we assume a very, very simplistic model. And in this simplistic model, how much you improve in therapy is related to two things, and only two things. The two things are your prognosis, your overall prognosis, and the quality of the treatment, which may vary to account for things like therapist effects, drift, differences in adherence, between therapist differences, and things of that nature. And we simulated two treatments that we said are going to be different in quality. Quality being all the things that are responsible for the efficacy of the treatment. And so we simulated a D-type effect size of 1, which, if you are a treatment researcher, and I know some of you are, is a huge difference. It's like the difference between doing CBT or really IPT or ACT, if you do ACT, versus not doing anything. So this is like a pretty big difference that we simulated in strength. And then assume that there is this difference in the prognosis. So we're saying there's a one end of the continuum where patients are intractable. They're unlikely to get better no matter what we do with them. So this is one extreme. Another extreme is patients are actually spontaneous remitters. They're going to get better no matter what. So it doesn't matter what you do with them, they will get better. And I've listed in the slide some variables that I think could put you more in one direction than another. But it's just hypothetical at this point. And we can think of a midpoint. And the midpoint is like the kind of patient that will get better, but only insofar as they get a really, really good treatment. So these are like the perfect patients to have in your treatment study, because if you have a good treatment, they will show it. I'm simplifying it as if it were 3 categories, but of course we're thinking this is a continuum that people may fall on at different sides of the continuum. Now, one of the problems that we have in this kind of work is that we don't know, assuming that this variable were real, which we don't think it's just one continuum, it's likely several, we don't really know how it's distributed. So for this simulation project, what we did is, keeping it very simple, we said, well, let's just make 4 different assumptions about how it could be distributed. And I'm listing the distributions up here just so you have a general sense of what I'm doing, but I'll maybe slow down a little bit and explain each of them to give you a better sense of what they look like. And so what we did in this study is we simulate 4,000 studies covering these 4 different distributions, assuming that you're doing 1,000 studies that have sample size of 200, which is pretty large for a treatment study. And then we look at what kind of treatment differences we are able to recover and what the power to detect differences is on average. So the easiest scenario that we could say is, well, let's just assume that everybody is pliant. Let's assume that really nobody has a prognosis that's very extreme. People are going to get better if they get a good treatment. This is a scenario that is super unrealistic, right? It's saying basically only the quality of the treatment matters and the patient is not bringing anything into it. And of course, if you are inclined to thinking more in quantitative terms, you should know I created the simulation to have a D-type effect size of 1 between the treatments, right? When the quality is what matters. So if the patients are all pliant, then what the simulation is going to recover is that there's a D-type effect size difference of 1 between the treatments. and power is 100, right? So you're just recovering the same thing that you entered into the simulation. This is where it starts getting a little bit interesting. What if we say that it's not that everybody is blind, but that most people are? So the distribution of the prognosis looks a little bit like this. There's a lot of people in the middle where they're only the therapy quality matters, but there's a little bit of variability. I also think that this is kind of an unrealistic scenario based on what we know about the natural course of depression. But you could think maybe if the RDoC really works out and we get really good biomarkers, maybe this could be a scenario. Or like if you really targeted your entry criteria so that you are getting people who are severe enough that they can benefit from treatment, but not too severe that they're not going to fail to benefit, or that they're chronic so that they're a little bit chronic so it's not going to weigh on their own, but it's not too chronic so that they need very intense treatment. Now in this scenario, power is reasonably good, so it's 0.96, but then on average, you're only recovering roughly half of the treatment effect when you're allowing just a bit of variability in the prognosis. So even this highly unrealistic scenario suggests that if it's true that patients vary on prognosis, it may be very difficult to recover even large treatment effects. My favorite scenario is what happens when most people are prone to getting better on their own. So most of them are easy, quote unquote. By the way, I have this habit of doing quotation marks a lot when I am on Zoom. I don't know how I've been doing with that right now, but if you see a quotation mark that you feel is not there, it's just a thing I do sometimes on Zoom. So I think this distribution that's predominantly easy, in my estimation, is a characteristic of what I think is probably true of the category of major depressive disorder. You have this kind of skew to the right where a lot of people are kind of going to improve on average, but it's not like you're failing to capture intractable. There are some intractable people or some people who have a really bad prognosis. There's just much fewer of them. Now, in that scenario, what you get is that the average D-type effect size is a 0.22. So by conventional standards, small. And power is very low. Interestingly enough, this D-type effect size of 0.2, if you follow Pim Kuipers and all the meta-analyses that he publishes, sometimes IPT in the meta-analyses when compared to other therapies. And again, I know that some people don't think these are useful comparisons, but in some of those meta-analyses, the D-type effect size between IPT and other therapies is a 0.2. So I don't think that we're emulating the data generating process very closely here, but if we were, you could still get a 0.22 even if IPT was much stronger than some other treatment. The last scenario I don't think is very informative. It's just like, what happens if you make no assumption, or the assumption is every prognosis is equally likely to happen? And what happens there basically is like it's a crapshoot at that point, right? Power is very low, and there's almost no difference between the two treatments. So I think this is a work that I really like a lot, and it's computational, and so it's really kind of theoretical. But it does make the case that if there were heterogeneity in the response patterns, it would place an upper limit on our ability to identify treatment effects, even when we know that the treatments have a large difference. So I could be really cute and do the simulation again, and then change the code for it to say D equals 0.5 instead of 0.1, and the situation would just look a lot worse, right? It would just be harder to recover that now moderate difference. But the question that you all probably are caring about at this point is, does it actually, right? It's really nice to program this in R, but is this real? And the answer is, I don't know, right? Like my entire research program is devoted to this. I don't know. But we have a couple of clues from randomized controlled trials that there could be some validity to this way of thinking. So this is a recent reanalysis I did of the treatment for adolescent depression study. And the TATS is a very interesting study in which you can study heterogeneity because it has a placebo group. You could think of the placebo group as revealing something about the prognosis of individuals, right? It's kind of outcomes when you're not getting treatment, but you're getting kind of some minimal treatment. So you could think of that as an imperfect indicator of a prognosis. And then you have CBT and antidepressants, which by definition are weaker treatments than combination, right? If combination is made up of CBT and antidepressant, then combination is stronger and CBT and antidepressants are weaker. So in TADS, what we did is we used ElasticNet to build a model of the placebo response. Once we have this placebo prognostic index, we use it to predict outcomes in CBT, combination treatment, and antidepressants, and then say, let's forget about the placebo group at that point, right? They helped us develop the model, and now we're not doing really anything with them. And we can explore whether this prognosis variable is a moderator of outcomes between the three treatment conditions. And my hypothesis, of course, being that the differences between the strong and weak treatment varies across levels of heterogeneity of the prognosis. I'm showing here the prognostic index that we developed in TADS. It's predicted by some usual suspects, like severity is the big variable, and also whether the person reports sleep problems. And if they have low expectations for treatment, that also means that you end the placebo condition with higher depressive symptoms. But so now we have this continuum that we developed in the placebo condition. We can apply it to the patients in the treatment conditions and see how do we think they would have done if they had gotten the placebo treatment, which of course they didn't. So again, what I'm expecting is if the prognosis is really good, if they're going to get better on average, then really there shouldn't be differences between the treatments. But for the more difficult patients, we should see the combination is more effective than either of its constituents. And basically, we get an interaction between the prognosis variable and the treatment conditions, so that if you are a patient who has a good prognosis, the differences between the treatments are not statistically significant, right? Even though combination is supposed to be better than CBT or medication. And combination still has a little bit of an edge, but it's smaller than what was reported in the main trial, and also not statistically significant. In the people with a poor prognosis, so the people who were not expected to get better, had they gotten the placebo condition, you get this kind of stepwise thing where the medications are better than CBT, the combination treatment is better than CBT, and certainly the combination treatment is better than medications. And I don't know what one of the contrasts isn't showing up here. I don't know why. So I apologize for that. But you get this kind of stepwise effect where the stronger differences are revealed in patients who are not expected to be placebo responders. I really like this study because a lot of times people will write these papers about, identifying predictors of the placebo response and developing a machine learning algorithm to develop the placebo response. And it's usually like implied that if we were able to identify placebo responders, all of a sudden research would be better. But not a lot of times people show how it could be better. So this could be one way in which it could be better in the sense that we could stratify patients and do outcome research in patients that we may not expect to get benefit with minimal interventions or placebo. Other studies from my group and others supports the idea that risk stratification by prognosis can help you identify differences between treatments. So this is a study from my doctoral dissertation, and it used data from a randomized controlled trial in the Netherlands, where Annemieke van Straten and her colleagues, they randomized people to 3 treatment conditions. One treatment condition was CBT, and a reasonably standard way of doing CBT. The other treatment condition was TAU, or treatment as usual. And at the time in the Netherlands, treatment as usual was what was called matched care. And it was basically an effort to, for people on a site to send you to the kind of therapist they think you would benefit a lot from. So it could differ in intensity, it could be different in individual versus group format, it could differ in therapy orientation. But it was basically using clinical intuition, which if you follow this literature, we don't have reasons to think is great. So it was comparing CBT to that treatment condition. And then the kind of interesting thing about that study is that it also had a control that was brief therapy, that was where the therapy was not just brief, but it was also kind of non-specific. So what it was meant to do really was foster hope, do a lot of active listening, and maybe help the person clarify problems and foster them coping on their own in a way that has been successful to them in the past. So it was kind of like a brief solution-focused therapy control. So I think this is a very interesting trial because you have a difference in the dosage. So the TAU and CBT have more than the brief therapy, but you also have a difference in the techniques. So the CBT is more CBT than either of the therapies is CBT. And in the initial trial, what they found was that the experimental conditions, the brief therapy and the CBT, you could say that they beat treatment as usual if you're focusing on the raw numbers, but really there are no significant differences between the three approaches. So what I asked with these data is, well, what if you focus on the prognostic status as a moderator? And this graph, what it shows is the percentage of people who recovered from their MDD diagnosis in the long term. And you can see there are no differences between the three treatment conditions. When we explore whether the prognostic variable is a moderator, as it was in the TAD study, we also get significant results. And when you explore that interaction with this is what the model looks like, by the way. The odds of recovery are a function largely of unemployment status, severity, anger, sleep problems, and to a lesser extent, severity. So these 5 variables, which have been reported previously in the literature, predict your prognostic status in this sample. And jointly, they moderate outcomes so that for 73% of the sample, there are no differences between the 3 treatments in the way that it was reported in the original trial. So if you have a good prognosis, if you're kind of naturally inclined to get better, it doesn't really matter whether you get a full course of CBT, whether we do this matching thing, or whether you instead get a brief therapy. No differences. Meanwhile, for the patients who have a poor prognosis, by virtue of having more severe depression, more sleep problems, more anhedonia, more hostility, and also unemployment, CBT beats the non-specific therapy condition, which differs on technique, but also quantity of treatment. But it also beats the matched care condition, where there were more treatment sessions than in CBT. And so this trial, I think, also illustrates how when we look at these lack of significant differences between treatments that differ in their strength or that differ in their technique, but it may be that there are subgroups that are meaningful just on this one variable that I'm calling prognosis to mean kind of like what would be the natural course of your depression. I really like these studies. They have a lot of features, I think, that I like, but by prediction standards, these are small studies. So the simulation work on this suggests that you need at least to have 200 people, 300 people for cell size, in each treatment to make reliable predictions of the effects of using these multivariable algorithms. So this is one of those areas where I'm always gonna end up by saying we need to do more work here. And we need to get serious about doing work that has large samples and these prediction efforts. And I know some of your faculty are involved in this. Jamie Delgadillo in the UK has also done research that supports this idea that prognosis will reveal a treatment effect of a stronger versus a weak treatment. He uses naturalistic data sets, namely the IAP data set, and has several reanalyses that are very sophisticated. So Jaime Delgadillo, if you don't know him, I would definitely recommend you read his work. There are trade-offs to using naturalistic versus RCT data that hopefully I don't have to get into, but we can talk about the pros and cons. But his is work that I would read if you kind of like this argument, or at least if it makes sense to you. Now, I've been going on for a little bit, let's see, maybe for 40 minutes, without really talking a lot about mechanisms, which is something I alluded to earlier in the talk. So I'll try to briefly go over two studies from my doctoral dissertation that I think also make the case that these blanket conclusions that we make about mechanisms, we really need to be more sophisticated about them in the light of the variability and heterogeneity that there is in our data. So the working alliance, as I said before, I think is one of those constructs that people say a lot of things about, and the things aren't always really strongly connected to the data. So one of the things I noted on my when I was reading for my doctoral work is that people would say things like, the alliance always matters. It matters even more for some people. Usually personality disorders is the variable that gets mentioned in there, or some interpersonal skills or lack thereof. And to me, this is a question about moderation, right? Does the size of the relationship change in according to some patient feature? But in the literature, you didn't really see a lot of moderation studies. So one of my first papers at Penn was exploring moderators of the Alliance Outcome Association. And I did this, this was like my second year of graduate school, so there are a lot of criticisms to the method here, but I think it's a first stab at looking at heterogeneity and process outcome relationships. I did this in a study that had 60 patients, where the working alliance was rated by observers in session 3, which is early in therapy, but typical of these studies. And depression was assessed with the Beck Depression Inventory after that third assessment point. So we're looking at subsequent change. If you just focus on the trial overall, right, if you ignore patient features, what I'm showing here is a scatter plot of the alliance and subsequent change on the BDI. On the x-axis, you have the working alliance rating, where more means that the alliance was rated as more strongly. And on the y-axis, you have change in depression, where more means you change more. The R-type effect size of 0.24 means that, to me, that this is a typical alliance outcome study. It finds a correlation that's, I'm not putting it there, but it's statistically significant. The question I ask is that true across patient subgroups? And the way that I did this first was by identifying which of a set of variables interacted with the alliance in a way that was statistically significant. There were 23 variables I chose. Even back then, I knew that this is a lot of comparisons. So I had 23 variables, 4 looked like they interacted with the alliance, but only 4 of those interactions passed the correction for multiple comparison. And those interactions where the alliance interacted with anxiety, and it also interacted with the number of prior episodes. When I enter those interactions in a regression model simultaneously along with their lower order effects, the interaction of the alliance and prior episodes was the only one that was significant at p less than 0.05. At that point, it's very, very low p-value. And the interaction with anxiety kind of misses the 0.05 cutoff. But because this was already like a little bit of a fishing expedition, I chose to only focus on the prior episodes and not on the alliance, not on the anxiety correlation. And this is the way that it shakes out. The Johnson-Niemann technique basically splits the sample in two. It happens to do that in this sample, where there's roughly 30 people who have less recurrent depression. So they have 0 to 2 prior episodes coming into the trial. And in that group, what we see is that the alliance outcome correlation is a lot stronger than what is usually reported. So an R-type effect size of 0.52, of course, is statistically significant, and it's very large. I don't think I've seen this. I had seen this before in the alliance literature. But of course, the flip side of this is that there's a group in which the relationship is not statistically significant. So this group that has more prior episodes, roughly 30 people, so it's not a power thing, right? Or not in an easy way. You can see here that there's no relationship. sometimes this scatter plot looks to me like a turkey or like a chicken or maybe some kind of dinosaur, but like there's no linear or curvilinear relationship. It just seems like nothing is happening in this subgroup. When I started graduate school, I don't remember open science and replicability, at least in clinical spaces, being something that people talked about a lot. It wasn't as cool back then, or at least not in clinical. But I wanted to replicate these findings because I recognize that this is like a data mining process, right? And you can come up with a lot of post hoc explanations for it, but it's better to just try to replicate it a priori. And I did that in the trial that I mentioned very early on in the talk, which was by Ellen Dreesen, where she compared CBT to psychodynamic therapy. There were a lot of differences between that trial and the trial that I used in the past slide. The sample size is a big one, so it's 340 versus 60, so that's a big one. But the working alliance was assessed with a different questionnaire. Depression outcomes were assessed with different questionnaires and not at every time point. And the number of prior episodes was the way that it was assessed was more rough. Despite these differences, I actually find in this study that we replicate the effect that we previously reported in CBT. The alliance outcome correlation is very strong if you are coming into the trial with no previous episode of depression. And it becomes weaker the more that you are a person who has more recurrent depression. It's not that the outcomes are worse, it's not that the alliance is lower, it's that the alliance outcome association is weaker as depression gets more recurrent, at least in CBT. And the interesting thing about this study is that we don't recover that same pattern in psychodynamic therapy, where the alliance seems to predict outcomes irrespective of prior episodes. And I'm showing these analyses here as like a stratification, but in actuality, this is like a three-way interaction between treatment, prior episodes, and the alliance that is statistically significant in this trial. And so a couple of people have tried replicating this. It's replicated in one study, but failed to replicate with interpersonal therapy. If you ask me, interpersonal therapy could be a little bit more like this short-term psychodynamic therapy. So I would love to see more work done in this area. But one of the things I really, really like about this kind of work is that when you ask people to think about how to explain outcomes in psychotherapy, most of us think, well, the patients matter, the common factors matter, the specific elements may matter a little bit, but not a lot of people actually study that and look at the interaction of those variables. So for example, Larry Butler is a person who has done that, but not a lot of people are doing this kind of work. And certainly not in large samples using, I think, methods like replication and being mindful to temporality and other issues. So I think this is one line of work that I have that is really focused on the complexity of studying change in psychotherapy. And so, you can be cute and say it's just very complicated. In the past couple of years, I have also been doing research that is less complicated and that is focused on recognizing that a lot of people are going to benefit from low intensity treatments. So brief therapies that are non-specific. I know that in your faculty, you would know about, single session interventions. And so we want to do a better job of disseminating those treatments, identifying the kind of people who can really benefit from them versus who really needs to bypass those treatments and go on to a treatment that is more like what we traditionally consider face-to-face psychotherapy or even medications and their combination. So a lot of this recent work of mine is focused on secondary analyses, but also primary data collection of guided CBT self-help approaches over the internet or with bibliotherapy. But just in the interest of time, I'll stop there and say this is a direction in which I hope the field continues to move towards, in part because it's cheaper to do that kind of work, so it's easier to get larger samples to do to study prediction efforts. But I will end there, and I'm happy to take questions about the slides I covered, but also about the research on ICBT or guided self-help. And I can't see Zoom right now. It'd be really funny if I'd been muted this whole time.
So I have a question. I'm a graduate student, and I really appreciated your talk. I find the idea of looking at heterogeneity and prognosis really interesting, particularly with the idea of kind of toward the end there of like matching people to appropriate treatments and appropriate levels of care. It seems like the idea of the prognostic index or prognosis itself is, it has quite a bunch of different elements kind of included in it. And could be things like severity, so number of symptoms, or belonging to a high risk group, so endorsing something like thoughts of suicide, or even duration of episode. So I was curious, if we were to start using these prognostic indices to match people to treatments, if you felt like any one of those components of prognosis might be more or less important, and how you see that kind of applying moving forward.
Yeah, this is always a good question, and I think I put my own thoughts, Mallory, into your question, thinking, well, maybe it's not one element of prognosis, maybe it's two or three different, a bunch of different ones, right? So I'm acting like it's this latent variable that comes from a bunch of smaller things, but it could be multiple. So one of the things that often makes it into the models is severity. And so if you look at models of care like that use step care approaches, like in the UK, severity is often a variable, and it is in other areas of medicine as well. So I think that's a big one. In our data, sleep problems and unemployment have both come out several times now. So if I was putting money based on only my research, I would say, well, sleep problems and unemployment, I think, are big ones. I really care about duration, and I know some of you do as well. In some of the studies that we've looked at, it doesn't come out. I don't really know what to make of that. I think there's something about duration. I think it kind of interacts with severity. So it's not the same to always have this low level depression that you can't shake than to be severely depressed for years, than to have a severe depression that's very brief, right? And so I think, there's something there with duration, and some of you could school me on that, right? So I think that's a variable I would put money towards. So I think that's what I would, those are the variables that come to my mind. I would also say, and I sometimes make fun of this kind of open science and people whining on social media and stuff like that, but I do think this is one of the things that makes me care about replicability, right? Because if we knew about moderators that replicate, that would really push us forward in building this indices that we care about, right? Or that, maybe are really meaningful for psychotherapy, but are not meaningful for when you're comparing psychotherapy to antidepressants, right? Where for example, severity, at least severity as it's assessed on most questionnaires, doesn't really seem to do a good job of assigning patients to the treatments.
That was perfect. Thank you for answering my question. I really appreciate it.
And Matthew had a question.
I'm muted. Hi.
Yeah.
Thank you so much for this awesome talk. I've loved your work for a while, so it's really excited to hear what you're up to now. So I guess one thing, and I've thought about it, I was thinking about it kind of around the middle of your talk, and I had thought about it previously with your work on the personalized advantage index, now the prognostication index, right, is what you called it? Prognostic index, sorry. Prognostication is different. I guess, I've kind of, I don't know the mechanics of your model very well, but, I've sort of thought about what you're doing with these, in relation to the old Rubin propensity scores. And I feel like I have a general understanding of how they're different, but I think what you're doing, I'd love to hear your thoughts on kind of what's new and better about using these tools relative to the propensity scores.
Yeah, I don't really have any strong thoughts about that. I think I know Ron Kessler, who's doing some methods work on this, when they reanalyze treatment data, they use propensity scores to equate groups, even when it's a randomized study, so that they're roughly comparable in demographics, and then they create these prognostic index, and they have kind of a complicated, interesting way of doing it, where it's probably better, but I've never found a data set in which it matters a lot. So I think I don't really have any strong opinions on that. I will say that as much as I really like complicated stuff, I think sometimes we get, I think, fascinated by like, what's the next coding thing that I can do? And I know I have been guilty of that, I will admit, both by my doctoral work and right now. And I don't want to see another machine learning paper that doesn't test against something simple, like just using severity, right? I think I don't want to say it's dumb, because I know that I have done it and I've been in papers where it is, but we want to be serious about things being useful, right? And so if you have a little, this is being recorded, if you have a little thought exercise, that's great. But I also think, we're in a profession where that it's about people's lives, right? And it's not it matters, right? And so I do want the field to move towards a direction where, yeah, if we're doing something fancy, whether it's propensity scores or whether it's machine learning approaches that are kind of counterfactual, that are focused on the counterfactual, you please try to test it against something that's simpler.
I like it.
That probably does a good job of answering your question, right?
Gets to the heart of it.
Thank you.
I have a question, if there's time.
Yep.
Hello, thank you so much for doing this. This is so fascinating. I'm going to piggyback on Mallory's question and ask something related. In terms of thinking about developmental stage and what treatment is sort of like for younger kids, I'm thinking about the duration very differently for a child than for an adult, which of course makes sense, right? But that makes me wonder, what pieces of these factors do you think would apply most if you developmentally go a little bit downward? And also how sort of motivation for treatment in the first place might matter, given that youth usually don't choose to be in therapy, whereas adults do.
No,
So
that's an amazing question.
I'm curious about, so what do you think would be most important if you had to guess? I know there may not be empirical.
So I am not a developmentalist by training. And actually some of my first entry into research was coding psychotherapy studies of suicidal adolescents who had suicidal ideas. And it gave me the message that I didn't really want to work with adolescents. I find it like heartbreaking. But that's neither here nor there. But in this TADS paper, I recruited colleagues who were developmentalists to help me think about that aspect of it. So Tanisha Riley, who was a colleague on that paper, is a developmentalist. And, I think she has thought about variables like impulsivity and where adolescents are on that individual difference, but also developmentally where we would expect them to be. And that, I don't think impulsivity stands out to me as a variable that I think about a lot in adults in the treatment of depression, but that I can kind of understand how, if you're working with adolescents, they may not be at a stage cognitively where this treatment that we're doing that is very focused on can you think, and can you meta think, and can you stop and think, and can you plan? So that's one variable that I would talk about. But you know what, God, even just considering age. So we love complaining about the things that don't replicate, but I think in Pim Kuiper's work now, age seems like it predicts the effect size of therapy, and it also predicts in the individual patient data analyses, it predicts dropout. And my understanding of it is the younger you are, the more likely you are to drop out of guided self-help treatments. So I actually think I'm not doing as much work on this as I would like, but I have a lot of ideas about increasing engagement that I think for our youth are really where we should be focusing on. Because I mean, in our open trial right now, we weren't getting enough people through to the stage where they were coming to this first session. So I made a small change to the Facebook advertisement, and I said, well, let me try to advertise more to people who are a little bit older. And all of a sudden, the people that we have now are all showing up, right? It's, that was a very dramatic thing, and it could have been related to a lot of things. But I think even just thinking about the fact that age matters, right, is important for people like me who are used to thinking about adults, period, as if that were a meaningful category. So that's one general reaction, but I think specifically impulsivity is one variable. Judy Garber's work would make me think that whether the parent is depressed is also something that matters. So if you're somebody that thinks kind of in a systems way, this of course makes perfect sense to you. So that could be another variable that I would be willing to put money behind, is whether the parents are depressed.
Thank you.
And I didn't speak on motivation for treatment because the way that I think about it is it probably always matters, right? The more motivated, the more you're to either do or complete or have processes that matter or whatever. So I think of that one as maybe it's lower in youth. I don't know if I know enough to say, oh, it's a fundamentally different process, other than just on average, it could be lower. So I didn't speak on that for that reason.
Perfect. I think that's it for today in terms of time, but thank you everyone for coming out, and thank you to Dr. Lorenzo-Luaces for speaking. This is really great work. So thanks everyone.
Thank you all for having me. Oh, so let me know where I can access this. Maybe you already sent me an email about that.
Yeah, I can follow up about the recording and all of that. So I'll make sure you get.
Great, thank you.
Yeah. Anything else that you want us to go over?
Nope, this is excellent. Thank you.
TJ and Lorenzo, can I just follow up on the recording thing?
Oh, yeah.
Lorenzo, on the SSCP website, we do these diversity virtual clinical lunches. And so I don't know if TJ spoke with you specifically about that, but if you're interested and willing, we could consider having the recording included on the SSCP website.